So the ASPIRE study has a very interesting background. For prostate cancer, we have very new and life-prolonging treatments in hand. And the last 4 years, I think, were very exciting for the treatment of prostate cancer. There are life-prolonging treatments like observational and enzalutamide, like docetaxel, carboplatin, and radium-223. In addition, there is also immunotherapy that is available only in the US and not in Europe. But still, there are several options. And the guidelines in Europe and the guidelines in the US, in North America, they all recommend to use those drugs. But there are no specific recommendations how to use them and how to sequence them. So this is one of the backgrounds. The background is that we actually don't really know how to best use them, and we are not sure how they are really used in daily practice. In particular, in the practice outside of Europe and the US. So, for example, in North Africa, in the Asia-Pacific, in Latin America. For those countries and in many areas of the world, we do not have good information of how the treatment paradigm is in prostate cancer and how the new drugs are delivered if patients really get them, and how daily practice is working. So this is one background of the ASPIRE study, and I think the most important. So what we try in the ASPIRE study is to get information, prospectively collected information on the treatment paradigm in those countries. Less in Europe and in the US, but in those countries where there is a real lack of information, like I already said, Latin America and North Africa, Asia Pacific. So in the ASPIRE study, patients are included with newly diagnosed metastatic prostate cancer, those with newly diagnosed castration-resistant prostate cancer, and also those with a biochemical failure after curative treatment for their prostate cancer. What we want to capture in this study is not only the kind of treatment and the treatment decisions, but also on which criteria the treatment decisions are based on. If it is just PSA testing, or if it is also radiography, which radiography, if it is only bone scan or CT scans, MRI, or all the other fancy imaging possibilities we have nowadays, or if it is just symptoms of the patient. So this is actually what we don't know, what these treatment decisions are based on in many countries and in daily practice. So we are going to include 2,900 patients in this trial. So we will have, at the end of the day, we will have a huge body of data to provide us with this kind of information, and we hope to learn a lot from it. At this Congress, we actually present the first data. So far, 400 patients have been included, and the data we present are based on roughly 300 patients. We have learned, interestingly, that the majority of patients, actually 46%, are diagnosed with metastatic disease upfront, which is kind of surprising, but which might also change. The proportion might change as the study goes on, and when at the end of the day, having included 2,900, the picture might also be quite different. But right now it is the majority of patients with metastatic disease. This brings about a new question. How were those patients treated with newly diagnosed metastatic disease? Patients that usually, like the old standard, started with androgen deprivation therapy. And we found out that those patients, the majority of those patients actually received androgen deprivation therapy alone, without any other treatments and without chemotherapy, which most probably will be the standard of care very soon. So it will also be quite interesting to see how this treatment of the patients with newly diagnosed metastatic disease will change over time with more patients included within the next few years, maybe the next 1 or 2 years. How would this data change daily practice? What would the patients get out of it? We might derive programs, for example, for countries where we see that treatments have not been endorsed that we regard as standard of care in Europe and in the US, for example. We might feel obliged to bring different treatments, life-prolonging treatments, also to those countries. We might feel that educational programs might be appropriate for both physicians and patients in those countries. We might learn at the end of the day that in those countries in 3 or 4 years, standard of care is what we think it should be, and this would be actually the best thing to capture if we had the data for it.